Good evening, and thank you for joining us. My name is Steven Horwitz, and I'm an attending physician on the lymphoma service at Memorial Sloan Kettering Cancer Center. And what I'd like to talk about today is basically a pretty broad overview of non-Hodgkin's lymphoma. We'll kind of walk through what the disease is, how we go about diagnosing it, different types of treatments, and then go through questions from the audience. So let's get started. Just a little bit of an overview of what I'm going to talk about. I'll say what is lymphoma. I'll try to explain a bit what type of cancer this is, talk about how we make the diagnosis, and spend a little bit of time on this, as this is one of the more critical aspects. Talk briefly about staging, treatments that are available, including conventional and a number of new treatments, and then lots of questions. So what is lymphoma? So lymphoma is really a heterogeneous or a complicated group of cancers derived from a kind of white blood cell called a lymphocyte. We all have normal white blood cells in our body, and one of the more common types of white blood cells is a lymphocyte, and we basically divide those into three different kinds of cells. Now again, here we're talking about normal cells of the immune system, and those are called B cells, T cells, or NK cells, and those names just come from either how those cells develop or the normal job they do in the immune system. Normally, lymphocytes, which again we all have in our body, are used to fight infections, primarily viruses and to a certain extent bacteria, fungi, and other foreign organisms. And as we're learning these days, sometimes lymphocytes can even be induced to fight cancer. Lymphocytes travel in the lymphatic system, which is a network in the body of basically tubes where the lymphocytes travel. They primarily live in lymph nodes. And these cells hang out in lymph nodes. They can grow and divide in response to infection where their job is to fight infection. But because they're cells of the immune system, they're also in all parts of the body. I'll show you that in a second. So what is basically lymphoma? So lymphoma is what we call a malignant or clonal expansion of a lymphocyte. So normally, if you look on the left, we have all different lymphocytes in our body, and these, again, are cells that are primed to fight infection. If you get a flu shot, the cells that grow up and develop in response to the flu shot are generally lymphocytes, and then if your body encounters influenza, those cells are there, they can grow and divide and fight the infection. And if you sort of look on the left, we have all different kinds of lymphocytes in our body where each cell would be different. What happens in really any cancer, including lymphoma, is we get something called a clonal expansion. So for instance, one cell here, this one, say in pink with a dark blue center or nucleus, that cell takes on some defect or some change that it now starts to divide too frequently, or it loses the ability to die normally. So one way or another, that cell starts to reproduce itself too much, and it grows, and you get copies of that cells over multiple generations. They accumulate, and that's basically what a lymphoma is. Now this is just a picture of a body with the lymphatic system. Again, you have these tubes where the lymphocytes or white blood cells run that kind of follow the blood vessels. There's organs where lymphocytes tend to cluster. These are things called the thymus, which in younger people is where a lot of lymphocytes develop. The spleen, which is in some way a very large lymph node. It contains a lot of blood, including a lot of white blood cells. And then lymph nodes. And lymph nodes are everywhere throughout the body, though people who've had experience with this know that when people get a lymphoma or when they get an infection, the lymph nodes that swell that we notice are generally in places where we can feel them or where the lymph nodes are close to the skin. And this includes the neck, under the arms, and in the groin. The normal response of lymph nodes to an infection is to swell, and people get swollen nodes, swollen lymph nodes that might be tender. They fight off the infection, then those nodes calm down. When you have a lymphoma, again, those cells are growing not because the immune system is telling them to, but they're really growing for no reason or because of a defect that makes those cells grow in an uncontrolled way. Typically, because lymphocytes hang out in lymph nodes, most lymphomas present or first show up in lymph nodes, but again, they're immune cells. So we have immune tissue like that in every part of the body, lymph nodes, in the brain, in the skin, in the lungs, and really a lymphoma can develop in any organ. This is just a list of the different types of lymphoma based on the latest classification. So I understand that on the web you guys can't read this, but there's an organization called the World Health Organization, and one of the jobs of that organization is to classify malignancies. And this last classification was made in 2008, and at that time there were more than 60 different subtypes, recognized subtypes of lymphoma. So when we say someone has lymphoma, we're really talking about this very broad group of diseases, and we'll get into a little bit of the specifics in terms of of how we separate those out. But suffice to say, the list is very long, and just saying someone has lymphoma is pretty nonspecific in terms of really understanding what disease they have. There's different ways of thinking about the lymphoma to try to break that down. I think from the patient standpoint, the most important thing is to understand what kind of lymphoma you have and not worry about all the other subtypes, because it can get a little daunting. But at least in terms of an understanding, one of the ways the doctors most commonly think about this is based on what we call cell of origin. Or again, there's different kinds of lymphocytes in the bodies, B cells, T cells, and NK cells. If a normal B cell becomes a cancer and grows up inappropriately, we call that a B cell lymphoma. If a normal T cell becomes a cancer, we call that a T cell lymphoma, et cetera. And if you look here, so on the pie on the upper left, about 90% of lymphomas that develop each year in the United States and Western Europe are B cell lymphomas. T cell lymphomas make up about 10% or so, and then a couple percent would be NK lymphomas. In the Far East, there's a relatively increased incidence of T cell lymphomas, but in the West, about 90% would be B cell lymphomas. I think other terms you'll hear are non-Hodgkin's lymphoma and Hodgkin lymphoma. Hodgkin lymphoma was described first. That's a less common type of lymphoma, and really every other kind of lymphoma is called a non-Hodgkin lymphoma, and we're going to focus primarily on non-Hodgkin lymphoma today. Probably beyond the names in terms of how doctors think about them, probably what's most useful, I think, from a patient perspective or even from a physician's perspective in terms of how you think about these is conceptually how they behave and how we approach them. So there's some clinical schemes to kind of classify the lymphomas, again, taking those 60 or so subtypes and separating them out into different subtypes. There's something that used to be called low-grade lymphoma. The term now indolent lymphoma is generally a slow-growing lymphoma, and that's one group of diseases. There's a group of diseases that used to be called intermediate grade and now are more often called aggressive lymphomas. And there's a group of diseases called highly aggressive or high-grade lymphomas. The way when these schemes were first put together, in very simple terms, low-grade lymphomas tend to grow over years. Intermediate-grade lymphomas or aggressive lymphomas tend to grow over months, and high-grade or highly aggressive lymphomas tend to grow over weeks. So these terms really describe the growth patterns. However, we can add a little bit more context to those in terms of what happens to people or how we approach them. Slow-growing lymphomas in general are very treatable. We have a lot of medicines that can make these better, but they're generally not curable. And by what we mean by not curable is that with standard therapies that we would commonly use, chemotherapy, radiation, some of the new therapies we'll talk about, the lymphomas would often get better or even go into remission, but they would almost always come back. The one exception to that would be a treatment with a bone marrow transplant from another person. And that's a situation where generally incurable lymphomas can be cured. But for purposes of classification, we don't usually count that as a standard therapy. It has a little bit more risk, and it's usually done in very specific circumstances. Intermediate grade lymphomas or aggressive lymphomas are kind of the opposite, meaning they grow quickly, they tend to make people sick, they're treatable, and with adequate treatment, which is usually chemotherapy or chemotherapy plus immune therapy or chemotherapy plus radiation, these are potentially curable. And when we use the term cure for lymphoma, we mean that the treatment would get rid of all evidence of disease, a person would be in remission, and that they would never relapse. They would go on and live a normal life without the lymphoma coming back. And the aggressive lymphomas are potentially curable. The same is generally true for the highly aggressive or high-grade lymphomas. These lymphomas tend to grow very quickly. These are uncommon lymphomas with the names like Burkitt lymphoma or lymphoblastic lymphoma. And those also, with very strong chemotherapy regimens, there's a chance that they can go away forever, that a person can be cured. So how common is lymphoma? I like to say that lymphoma, I think, is one of the more common of the uncommon cancers. So if you look at just the percentages of cancers and the number of cancers in the United States, this is data from 2006. 700,000 men and women each year are diagnosed with cancer. The most common cancers are prostate cancer, breast cancer, lung, colon, et cetera. If you look at sort of the less common lymphomas, non-Hodgkin lymphoma makes up about 4% of cancers in men and women. So in terms of those less common cancers, we do see it not infrequently. Moving on to diagnosis and workup. So the most important thing when someone is diagnosed with lymphoma is what specific kind that they have. More and more, the specific subtype matters in terms of what kind of treatments we use, what's likely to happen to that person, and really getting as accurate diagnosis as possible among those 60 or so entities is really important. The second question, usually after what the person has, is where do you have it? And we'll talk about this. This is called staging. This is really just an inventory with tests, scans, bone marrow biopsies to try to see where the lymphoma is and where it isn't in the body. Sometimes that has implications for therapy, sometimes prognosis. Certainly if we're trying to cure someone of their disease, we need to know where it is at the beginning so we can make sure it's gone at the end. And then what I think is probably the most important question, once you know what you have, is what are you going to do about it? What kinds of treatments are available? Are treatments even needed? And if they're needed, what's the likely outcome of those treatments? And more, we're seeing a wide range of treatment options for people newly diagnosed with lymphoma. Okay, so diagnosis. This is really achieved only through a biopsy. A scan cannot tell you have lymphoma. A scan cannot tell you what kind of lymphoma you have. But some tissue needs to be removed from your body with a needle or with surgery, and then that tissue needs to be reviewed by a pathologist. And that's the way you make a diagnosis, and that's the way you tell what subtype. There's two basic tests in terms of figuring out the diagnosis, something called routine histology, which I'll just show you some pictures of that in a minute, and then immunophenotyping. These are if you see your pathology reports and it says CD and then a number, CD20, CD30, et cetera. Those are ways, those stains, which I'll show you, which help the pathologist know what kind of cell it is and then what kind of lymphoma it is. And then I'll touch a little bit on some of the molecular genomic features, which are not that often these days in terms of lymphoma used to make the diagnosis, but more and more are adding some sort of prognostic information. And we think in the near future will be more and more important in guiding therapy. So this is just a picture of a slide. This is a histology slide. So if you have a biopsy of a lymph node, that tissue is preserved. Then very thin slices are made of it and it's put on a glass slide and a pathologist will look at it under a microscope. So if you just look here, these sort of dark small cells, if you can see the arrow, those are normal lymphocytes. And mixed in there are some big cells, and those are large lymphocytes, and those are really the cancer cells in this, and then there's different cells in the background. So a pathologist will initially just look at that and say, okay, I see lymphocytes, they look abnormal, this might be malignant, this might be lymphoma, let's do further tests to try to see if that's so, and see what type it is. Other basic things they look at are just the size of the cells. So if you know a little bit about some of the names of lymphoma, you couldn't read it on that really long list slide, but there's diseases called diffuse large B-cell lymphoma. So that's the most common type of lymphoma. And a pathologist would look here like on the left and see, look at these cells. These are lymphocytes, they're large. That puts it in the family of a large cell lymphoma, which would tell them certain things, and they could do more tests on the tissue to come to that diagnosis. If, in general, large cells go along with the more aggressive lymphomas. If most of the cells are small cells, then they would say this is a small cell lymphoma. Often small cells go along with more indolent lymphomas, but just that picture looking at the cells would lead the pathologist down a path to make the diagnosis. Other basic things, again, this is still what we call routine histology, just looking at slides. There's something called follicular diffuse. So the second most common type of lymphoma is called follicular lymphoma. This is a slow-growing lymphoma or an indolent lymphoma. In normal lymph nodes, there's lymphocytes are arranged in things we call follicles, and here you can kind of see some light circles where there's some different lymphocytes going on in some darker background area. Those are called follicles. So when a pathologist looks at a piece of a lymph node or a whole lymph node that's taken out, and they see what we call this follicular architecture, they're really thinking this is a follicular or low-grade lymphoma, and then they work it up along those lines. If there's no architecture seen, or the cells, if you can tell here, just grow through the normal architecture, so you really don't see any of these normal follicular structures, that's called diffuse. Again, this is just on a basic slide. It tells the pathologist this is probably in the family of aggressive lymphomas. Let me do more tests and work it up down that pathway. Once they have a basic sense of what they think it might be, they then do immunophenotyping. And those are tests to really see exactly what kind of cell they're dealing with and really give the lymphoma its best name so the clinician or the oncologist can figure out the best way to treat it. Immunohistochemistry is a way of looking at surface markers on cells. So this is a cartoon of a cell, very basic biology here. The membrane would sort of be this red on the outside of the cell. Inside of the cell from this cutaway is something called the nucleus. That's really where the DNA sits and a lot of business of the cell is conducted. On the outside of the cell, there's different features, and here you can see these sort of lumps or nodules here, and then we have things called antibodies. Antibodies are proteins that are normally made by lymphocytes. So when your body is fighting an infection, one of the first lines of defense is antibodies or proteins made by lymphocytes would attach to that bacteria or that virus and sort of signal the immune system to help get rid of that infection. Antibodies can be made in the laboratory that rather reacting against an infectious agent could react against a feature on the surface of a cell. So say this is CD20, which would be a feature on B cells. People can make antibodies that bind or attach to CD20. That antibody is then attached to a stain, which gives it a color. You take a glass slide, you expose the slide to the antibody stain, wash off the excess, and what's stuck will show you the antibody that you're looking at. I'll show you a picture of that in a second. So we use these to tell you what kind of cell it is. So for instance, CD3 would be a marker on T cells, and if we're worried it's a lymphoma and it shows with CD3, it'd show a T cell, we'd be worried it's a T cell lymphoma. In this picture here on the upper left, you see the sort of brown or orange stain around the outside of the cells. So those are cells that are marking for the stain for CD3. Those are T cells. If we look down here at the bottom left, CD20 is a marker that's on B cells. So you would bathe or incubate this slide with antibodies against CD20, wash off the excess, and where it sticks, you see those are all B cells. And if those were the cells the pathologist thought were the cancer cells, they would say that's a B cell lymphoma, and that would lead them towards the right diagnosis. Molecular genomic features I'm just going to touch on. So more and more we're sort of looking at what's going on inside the cell, understanding better about what are the things that are making the cell malignant, not just identifying it as a cancer cell and then saying what kind it is. There's a number of ways to do it. A lot of things you may read about these days include sequencing. This is an example of something called a gene signatures or gene expression signatures. So without getting this too complicated, in all the cells in your body, we have genes. These are your DNA, and these sort of are the messages that tell the cells what to do. And in different cells, different genes would be expressed or sort of turned on or active, and that tells a lot about how the cells behave. What can be done is you can take the DNA out of cells, and you can look at which genes are being expressed, and then people have been able to correlate that with certain kinds of lymphoma, and then within certain kinds of lymphoma, correlating that with different prognoses. So for example, in a disease called diffuse large B-cell lymphoma, where a lot of work has been done, that's the most common type of lymphoma. Again, that's aggressive lymphoma. We treat that with chemotherapy plus immunotherapy, or what's commonly called R-CHOP would be the most common regimen, and a lot of people, but not everybody, would be cured with that chemotherapy. If you look in studies at the gene signatures, you can divide people with diffuse large B-cell lymphoma into people that have one gene signature or certain genes are more expressed, and those people may have a relatively higher chance of being cured with the same therapy. Other people may have a different gene signature pattern that can be recognized, and those people may have a relatively lower chance of being cured with the same chemotherapy. Now, neither of those gene signatures is a fate, meaning it doesn't tell you for sure what's going to happen, but it can adjust the odds or affect the probability that someone would be cured with the same therapy. So that's something that's helpful for us to look at in terms of looking at prognosis, trying to decide whether we would add additional therapy for a person, or often comparing studies. Are the patients treated in one study similar to the patients treated in another study? But probably what's more important as the next step is if you can look at the gene signatures or the genes that are active in people who have a lower chance of being cured with standard therapy, it's an opportunity to think about new therapies, either to be tried to enhance that therapy that goes on, that's currently being given, or to look at targets of therapy, and we'll talk a little bit about that in terms of trying to devise new therapies that may be more effective in certain groups of patients. Hopefully that was clear. Moving on to biopsies. So again, you can't diagnose lymphoma from a scan or physical exam. You have to have a biopsy, and that means some tissue needs to be removed from the body. So there's 3 different types of biopsies, something called a fine needle aspirate. That's when a thin needle is inserted into a lymph node or other part of the body and cells are pulled out. There's a core needle biopsy, and that's when a slightly thicker needle is inserted and you get a core of tissue. I'll show you a picture of what that looks like. Or there's surgical biopsies. These are where an incision is made with a scalpel and either a whole lymph node or a piece of a lymph node or a piece of tissue is removed. These are what those biopsies look like. When you do a fine needle aspirate, you get a very small sample of tissue. Cells are pulled out in liquid suspension. They're kind of squirted onto a slide, and they can, the pathologist can look at those and see if those cells look like lymphoma. If you remember back to the other pictures I showed you, what you don't have here is any sense of architecture, how the cells are arranged with one another. So that's the smallest sample. And in general, it's very difficult to make a new diagnosis of lymphoma accurately from a fine needle aspirate. Not impossible, but difficult. A core needle, again, a piece of tissue, as you see here in the center, is removed. So this is sort of the hollow part of the inside of a needle. So you do get cells that are arranged together. You do have a sense of architecture. The advantage of this is that you can get a piece of tissue and you can do it less invasively, particularly if it's from a part deep inside the body and you don't want to do a large surgery. But in general, the best way to make a new diagnosis, particularly for the uncommon lymphomas, is to do a surgical biopsy where a whole lymph node or a whole piece of a lymph node is removed. And that really gives the pathologist the most tissue to work with to make a diagnosis. Once you know what you have, then we move on to staging. Most commonly staging these days includes a CT scan or a CAT scan. Often a PET scan is done. And for most lymphomas, though not all, a bone marrow biopsy is done to see if the lymphoma is in the bone marrow. Basically, what scans show you are where the disease is in the body and where it isn't. They give you a detailed inventory of where the lymphoma is so you can make sure that it's gone at the end, and they serve as a good baseline to assess response. So these are just a couple of examples of CAT scans. CAT scans, you're sort of looking up from someone's feet to their head, and these are slices, kind of cross-sectional slices. So in the top scan here, this is the person's right, this is their left. The black area is air, that's the lungs. The white here is bone, that's the spine. You're looking up. And what you could see is under this person's arms, if you see here, there's enlarged lymph nodes, these sort of round gray structures here, very similar down here. And you know these lymph nodes are enlarged, and if a person is known to have lymphoma, that's likely to be involved with lymphoma. PET scans show not size of lymph nodes, which CAT scans do, but they show what we call metabolic activity. So a little bit of radioactive sugar is injected, and certain tissues, including many cancers, take up that sugar. You can look at the PET scan and it would sort of glow, or most of that radioactivity is taken up where the lymphoma would be. In this case, it's a lymph node under the chest muscle, and you can see that that shows up very bright, and that's a very nice way to see where the lymphoma is. One of the nice things about PET scans is that you can look to evaluate response. So the panel on the top here shows a person with a new diagnosis of a T-cell lymphoma. They have PET avid or abnormal lymph nodes under the arm, and these are sort of in the middle part of the chest. And here's another lymph node over here. After chemotherapy, all those lymph nodes went away. If you see here, the lymph nodes have shrunk down to a normal size, and they no longer show up on the PET scan. And what you might notice if you're looking closely is that there's increased uptake, or this yellow here in the bones. And if anyone's had chemotherapy and then gets Neulasta or Neupogen, those medicines really stimulate the bone marrow to recover, and that'll show up on PET scan. That's not lymphoma there. That's just the body responding to growth factors. But this would be a complete remission by PET scan. So it's something that we can use to follow how our treatment's working. Bone marrow biopsy, I just won't talk about too much, but basically that's a needle test where you take a sample from inside the bone marrow because the scans that we have don't show inside the bone marrow very well. And for certain types of lymphoma, it's important to know whether it's in the bone marrow when you're starting. So types of treatment, I'll spend the rest of the time on this and kind of walk through. I'm not going to get into super specific treatments for different types of diseases because, as you see, there's so many different kinds, but I think we can tackle a lot of that in the questions. But I'll kind of just walk through the common types of treatments so we're all kind of oriented to that. Chemotherapy. So chemotherapy is the most common treatment for lymphoma. Chemotherapies work by relatively nonspecifically attacking dividing cells. So if this cell is dividing quickly, we know that chemotherapies, that dividing cells are more sensitive to many chemotherapies. So when the cells try to divide, they die. And most lymphoma cells, cancer cells in general, but in particular most lymphoma cells are dividing more actively than normal cells, and therefore you injure the cancer cells more than you injure the normal cells. The downside of that is you do injure normal cells. There's things like hair loss, the bone marrow is affected, so normal blood counts can be reduced, nails, sometimes the nerves get injured. So there are a lot of side effects to chemotherapy. And a lot of the research these days is looking at non-chemotherapy or what we call more targeted therapy. And a lot of that research is really exciting. I think, though, it's important to remember that chemotherapy is really responsible for most of the cures for lymphoma. Again, cure means the lymphoma goes away and it never comes back. And there's diseases like diffuse large cell lymphoma, the most common lymphoma, or Hodgkin lymphoma, where the majority of people are cured, and those cures are basically by chemotherapy. So even though they come with some side effects that we don't like, getting rid of the lymphoma forever is often the more important goal, though I think more and more we'll see targeted therapies being added to chemotherapy, or in certain cases potentially replacing chemotherapy. Radiation therapy works very similar to chemotherapy. It damages DNA. This exploits dividing cells. One of the differences of radiation therapy in terms of chemotherapy is something that's given inside the body, whether it's into the vein or by a pill. It gets into the blood and kind of travels throughout the body. Radiation is something that, in general, you're exposed to from outside the body. So if you had a lymph node under your arm, the radiation might be exposed from the outside just to that area, and it's a very effective treatment where you give it, but it wouldn't do anything to the other parts of the body. There are some other ways of giving radiation attached to antibodies inside the body that can more seek out the lymphoma cells, but in general, radiation is used as an external source. Radiation can cause some long-term damage to tissues, so it's really given in situations where we think that's the best treatment, or one area or another. In certain kinds of lymphoma, this is typical, where the lymphoma, for instance, in Hodgkin lymphoma, is mostly in the chest. Radiation is often added. There's a type of T-cell lymphoma or NK lymphoma that shows up in the nose. Radiation is often very effective for that. So radiation remains an important part of treatment for lymphoma, but it's more often given in smaller doses in smaller areas to the body, compared to some decades ago when really extended areas of radiation was used more commonly. Monoclonal antibodies are one of the important treatments for lymphoma. The most common one is an antibody called rituximab or Rituxan, so that was approved in the late 90s. That's an antibody to CD20, so again, if you can see here, these are proteins that bind to the surface of cells. There's now a number of antibodies or monoclonal antibodies that are used to treat cancer in general and lymphoma specifically. They work in different ways, some of them through complement-dependent cytotoxicity, or what we call antibody-dependent cytotoxicity, recruit normal cells of the immune system. So the antibody binds to the cell, they bring in the normal cells of the immune system, and those cells can then kill the cancer cell. Other antibodies induce what we call apoptosis. So again, without getting too detailed here, apoptosis is sort of a normal death pathway that cells undergo. So all cells in your body, they grow when they're supposed to, and they should die when they're supposed to. Your ears don't keep getting bigger and bigger. They grow to a point, then they stop. Skin cells replace themselves, but they don't grow endlessly. And some of that normal death is through a mechanism called apoptosis. So there's ways that antibodies binding to the outside of cells can stimulate a cell to undergo apoptosis. And one of the defects in a lot of lymphoma cells is that they no longer undergo normal apoptosis. There's now more conjugated antibodies, so there's a new medicine called brentuximab vedotin, or Adcetris. So this takes an antibody to a molecule called CD30 on the outside of cells and attaches a molecule of chemotherapy to the antibody. And in this case, the antibody CD30, when it binds to the cells, it doesn't very often kill the cancer cell. But by attaching a molecule of chemotherapy to it, the cell can take up the antibody and then sort of bring the chemotherapy, kind of like a Trojan horse, bring the chemotherapy inside the cell, and then just that cell that brings in the chemotherapy dies. And it's a way of giving chemotherapy in a more targeted way. And for a couple of uncommon types of lymphomas, something called anaplastic large cell lymphoma or Hodgkin lymphoma, this has been a very successful treatment even when other chemotherapies haven't worked. There's also ways of attaching radiation, as I mentioned before, to antibodies, and there's a couple of drugs that attach radiation to CD20 antibodies and therefore can deliver a small amount of radiation just to the tumors of B-cell lymphomas. Signaling pathways are a lot of what you'll hear about today. I'm going to talk just for a minute on those. So all cells have a cascade of events inside the cell. There's signals that sometimes come from the outside or sometimes go on the inside that tells the cell to grow and divide and behave in a certain way. And a lot of the abnormalities in cancer cells have to do with abnormalities in signaling pathways. There are now new medicines, often what are called small molecule inhibitors, which I'll show you in a second. These are often pill medicines, though not exclusively, that can interfere with some of these normal signaling pathways. So rather than indiscriminately killing dividing cells or targeting cells by markers on their surface, these are medicines that can get inside a cell and kind of disrupt the way the cell is trying to stay alive and grow. So for instance, in a cancer cell, you may have a protein that is expressed, and that protein may move and bind to another protein, and that causes that protein to do something. That protein may bind to another protein, go to the nucleus, tell the cell to grow and divide, and in a cancer cell, this may be one of the defects. So you can have cells grow, they can divide, they can spread out of a lymph node, they can grow other places. So there's now medicines, that, again, that can target these proteins. They sort of block these proteins from moving on to the next step or from passing on their signal to the next step and block some of those signals for cells to grow or divide. So this is a cartoon that looks at one of the signaling of a B-cell receptor pathway. So again, this is getting a little bit detailed, but the outside of normal B cells and B-cell lymphomas have something called a B-cell receptor, here shown called BCR. That B-cell receptor can get signals from the outside and then through various proteins. If you see here, SYK, BTK, et cetera, you may have heard some of these names. It can convey signals to the nucleus of the cell that tells that cell to grow and divide. There's a number of drugs now that can block different pathways of this signaling cascade. There's a drug that was called PCI 3275, now called ibrutinib, which is on fast track to be approved by the FDA. This is an oral drug that looks very good in some kinds of low-grade lymphoma and CLL. There's a drug that was called CAL-101, now called idelalisib, which is also being looked at primarily in low-grade lymphomas as well as some other lymphomas. And there's a number of new drugs that block levels in these pathways. In addition to these drugs potentially working very well, one of the exciting things about these drugs is that they tend to be oral and they tend to not have a lot of the side effects that you typically see with chemotherapy. And because of that, they can sometimes work where chemotherapy doesn't. And if they are working, people can often stay on them for long periods of time, which is more difficult with chemotherapy because of some of the side effects. And then immunomodulatory agents, which I'll just talk a little bit about. This is sort of this idea of seed versus soil. There's some recent articles in the New York Times talking about some of these drugs. These are drugs that block things called PD-1 or PD-1 ligand, and you may have read about these. I think they're in the Science Times the week before or last week. And what these drugs do is they can unleash some of the immune system. So we know or we now know that the immune system can sometimes can sometimes control cancer, can sometimes eradicate cancer. But cancer cells often devise ways to get around the immune system or even suppress the immune system. So there's a number of these drugs now that can block some of those signals or what we say sometimes take the brakes off the immune system or unleash an immune response. And these drugs have been looked at in all kinds of cancers. There's some of them are approved for diseases like melanoma, and they're starting to be looked at in lymphomas. And it looked like even though this is a cancer of lymphocytes, that still taking the brakes off normal lymphocytes, the body can fight lymphoma. These are in earlier trials in lymphoma, but some of these look quite promising. I'll just walk through that. And these are some of the specific medicines that are being looked at, anti-PD-1, anti-CTLA-4. And again, some of these are in studies for lymphoma. Some of these are approved for other kinds of cancers. I'm just going to touch base now on clinical trials and hopefully leave a little time for questions. Clinical trials are really important. We have actually quite good standard therapies for many lymphomas, but the way we figure out better therapies, learn and do better for people in general is through clinical trials. Phase 1 clinical trials are usually the earliest trials. These are either the first time a medicine is to be given to people, where you're really trying to figure out the right dose. These are often new drugs, or sometimes they might be a new combination of drugs that we already know a little bit about. These trials are usually reserved for people in whom have had some conventional treatment, because there are a lot of conventional treatments for lymphoma. But if those treatments haven't worked or have stopped working, phase 1 trials are a way to get early access or to look at some of the promising new medicines we have. The next step is phase 2. So phase 2 is usually where you're looking to see how well a medicine works. You've already done a phase 1 study and you think you know the right dose. I'll say none of these are placebo-controlled studies. These are studies where everyone gets the new medicines. And there's a couple of common scenarios for phase 2. Sometimes we have a new drug that in early studies look promising, and we want to see how well that drug works in a larger group of people with one type of lymphoma or another, or we might be looking at a new combination of drugs. Sometimes there's a drug that we already know works pretty well, but we're trying to look at it in a different disease or maybe a related disease. And those would often be done in phase 2 studies to try to get an early idea of how well a medicine works. And then lastly, there's phase 3 studies. In phase 3 studies, the goal is really to try to establish a new standard of care. So say we have a standard treatment that works well or works okay, and there's a reason to think a modification to that, adding a drug or something very different may be better. And then you look at this in a phase 3 study. And these are what we call randomized studies, where usually the patient and the doctor don't get to pick what treatment you're on. Sometimes these studies are blinded, meaning you don't know which treatment exactly you're getting, and sometimes they are placebo-controlled, meaning that you might be getting standard medicine plus a placebo versus standard medicine plus a new drug. But those are really the last step in really trying to prove scientifically that a new treatment is better. So I'll just finish up there. I think as an overview, lymphoma, it's a pretty complex family of cancers. Part of the complexity is the names, the many different subtypes, and it can get a little overwhelming if you really try to absorb that information. I think important take-home points before we get into some of the details is that you really need a good biopsy to make an accurate diagnosis. And really having the best understanding of what kind of lymphoma you have is really important to making the best management decisions down the road. For the most part, we don't know why most lymphomas develop, but some of these things are starting to be understood, and some of those things are suggesting some new therapies. Staging and prognosis, sort of tests that help us tell what's likely to happen to you, are important parts of the management for some lymphomas, though pretty much every lymphoma these days, there are treatments available, and staging is usually more of a look to see where the lymphoma is in the body, and less often these days it's really guiding the therapy. There's many new therapies for lymphoma. A lot of these are exciting, and a lot of these have come out of a better understanding of either why lymphoma cells develop or why lymphoma cells grow. And the hope is that if these therapies are successful, we'll have better targeted therapies that actually will work better and have less side effects. Though I would again stress that most of the cures we have in lymphoma these days, and a lot of people are cured, are still with basic treatments like chemotherapy or radiation therapy. So as we develop new treatments, we don't want to abandon the older treatments that are working well unless we clearly have something better. And then again, really to stress the importance of clinical trials. Whenever appropriate, participation in a clinical trial is good for the community in general and often good for the patients who participate. So I thank you for your attention. I'm just going to show our Sloan Kettering website, lymphoma website, where there's a list of ongoing lymphoma clinical trials. Many cancer centers around the country have similar websites, and there's also NCI registry for clinical trials if you're looking for that. So I'll leave that up, and then we'll move to questions.